Okay.
And we're going? We're off and running?
Yes.
Okay. Hey there. It's time to get started. Again, if you don't know me, my name is Rob. I'm a registered nurse. I also teach in the School of Nursing here at Sac State. And the topic today I thought might be appropriate, applicable, is about sleep apnea. And the reason why I titled this Sleep Apnea, a look at a silent killer, is because in some cases, people have died in the middle of sleep because the oxygen is cut off. And if they don't have a device to help them breathe, like a CPAP or some other appliance, then they don't wake up the next morning. So in that sense, it is a silent killer. So we're going to talk about what is sleep apnea, and we're going to get into how is it identified? How do you know you have it or not? And then how is it treated? How is sleep apnea treated? And then what are some of the consequences of untreated sleep apnea? Okay. Let's go on to the next slide here. Okay. Basically, sleep apnea is really all about the airway. And what you're seeing on the screen right here is an individual in a cutaway who is, you can see the tongue represented here by this large solid mass here of tissue. When it's open, you breathe pretty naturally, inhale, exhale, and you stay oxygenated, okay? When there is an occlusion, typically it's the tongue or it's extra growth of tissue here in the back of the throat, it blocks the airway or occludes the airway. And simply put, your body begins to build up carbon dioxide. And on the other hand, it tends to not get enough oxygen because you're just not breathing it in, okay? And also, along with the tongue being an obstructive form of sleep apnea, if you're breathing through the nose, it still has to go in through the same passageway to make it into the lungs. So you may typically have a clear sinus or clear breathing airway through the nose, but if this is blocked, you're in trouble. So here's a little bit in some of the statistics. It is the most common type, the obstructive type of sleep apnea, where there is a blockage. It's either the tissue has collapsed on the airway or the tongue has collapsed over the airway, and it causes an obstruction, resulting in decreased levels of oxygen in your blood. And when you think about it, without that oxygen, your tissues will begin to die. And you need oxygen all over the body. Your organs need it, and your brain too, especially. According to this graph here, 1 in 15 individuals, 1 in 15 Americans have sleep apnea. At least that's how they determined it. Now, how many have it and are undiagnosed may actually be a factor in that 1 in 15, or the numbers might actually be greater than 1 in 15. And apnea can actually occur in younger individuals, college age, even down to 2 to 8 years old, which surprised me, but I'm not a pediatric nurse. I'm an adult and older adult nurse. So that number surprises me, but on the other hand, I guess it would depend on what's going on with that, that individual at a young age. But the bulk of your numbers in sleep apnea come from individuals over 65 years of age. That's where a lot of it is seen. And as you can see right here, it looks like 1 in 4 older adults has apnea. Am I going too fast? Can you hear me?
Yes, and you're not
Okay.
going too fast.
Okay, thank you. All right. What's happening to the airway during an event like a sleep apneic event? Well, there are three types that are commonly known. And one is, I just mentioned it, obstructive or mechanical sleep apnea. It's the most common sleep apnea that's diagnosed. And of course, you know it happens when there is a complete or partial airway collapse, resulting basically in the blockage of the central airway system to your lungs and back. The other kind, which is a little less common, but no less, I want to say, no less troublesome and serious, is the central form of sleep apnea. And what happens is this occurs when your brain fails to transmit the necessary signals to your breathing muscles to go to breathe in and out and help your lungs breathe while you're asleep. Is an automatic feedback mechanism. There's trouble there. Something isn't responding. And that signal to your diaphragmatic muscles and your other accessory breathing muscles, it's not happening where it should. So that is kind of, I want to say that's the nervous system component, or it actually may be a metabolic component too, depending on, if there's a medication or medications responsible for that central response. And then the last one is kind of a mix or complex sleep apnea. And actually, that's the kind of sleep apnea I have. I have a mixture of the obstructive and the central form of sleep apnea. And this sleep apnea can actually occur with some users who are on a CPAP already. So they call it, there's another name for it, they call it treatment emergent central sleep apnea. And that is kind of, without going into the complexities of that. And I think the numbers on that particular kind of sleep apnea are much rarer, but it does occur. But the most common is the obstructive form. Airway collapses, blocks, oxygen coming in and CO2 going out. So I put a little Mayo Clinic, a link here because a lot of this information does come from the Mayo Clinic. All right, here's something that I never quite thought of, but it makes sense to me. And this is OSA's obstructive sleep apnea. You'll see that abbreviation used commonly. If you look at these 4 pictures, you'll see that the individuals who have, that you can actually see the back of the throat and the uvula, which is that spot in the back of the throat that dangles from the roof of your mouth. If it's easily visible when the patient or the client says, ah, there are ways of predicting whether or not this individual has or could, have problems with sleep apnea. Generally speaking, it's the bottom 2 that are more concerning. And it's pretty obvious, I would think. The airway here is pretty large. The opening, there's fewer obstructions here with A and B. C and D, you can't even spot the uvula. It's almost completely obscured here, and it's completely gone here. So that may mean that there's trouble with additional tissue, and it could be, due to either, I want to say, for lack of a way of putting it, more tissue to the tongue and the back of the throat, or the structure of your jaw. I want to say the lower jaw. That's responsible for that crowding in the back of the mouth and the oral pharynx. Okay. So, but you can see clearly the differences between D and A. Okay. Does that make sense? I hope. That's kind of a predictor. It's kind of a predictor. And here's another way of looking at sleep apnea and what's going on with, air exchange, because that's basically what we're looking at. Normal airflow. You have a wider airway, and that means you'll have a much more normal oxygenation. And because of that, tissues of your body will stay and remain healthy. On the other hand, with sleep apnea, whether it's central or obstructive, you have a narrower airway. And then that actually results in lower oxygen all over the body, not just the brain and at the level of air exchange in the lungs, but all over, tissues everywhere, including the heart. You will have a much more stressed pump with there's lower oxygen and less exchange of that CO2 and oxygen going on between the time it reaches the heart to the lungs and out through the airway. Now here's another way of looking at the two types of apnea. Obstructive, of course, means that there is something restricting or blocking the free exchange of air, oxygen, and CO2. It's an obstruction. Central apnea, on the other hand, refers to something lower on the level of the lungs and the muscles surrounding the lungs and the heart. The function is off. It's the controls that usually dictate that functioning it's not reaching those muscles in the automatic way that it usually does, or it should, with everything else given as being normal and not changed. So again, going over obstructive apnea, it's usually the most common kind of thing is the muscles in the back of your throat relax during sleep. And that also might be affected by the angle that you sleep. You sleep on a flat back versus sleeping on your side. Do you sleep, sleep positioning makes a lot of difference as you're going to sleep and trying to maintain sleep. So the muscles that support the soft palate that's down below and the triangular piece of tissue hanging from the soft palate, upper palate, pardon me. The uvula, the tonsils and the side walls of the throat and the tongue, something's going on there either to cause a complete collapse or partial collapse of all those structures put together to block the airway. So when the muscles relax, your airway would open, given everything else being the same, and also close when you take a breath in and out. But if with sleep apnea, that airway narrows and may be so narrowed it's completely blocked, you can't get enough air in, which will lower your oxygenation levels in your blood. And your brain usually will sense this inability to breathe and briefly rouses you from your sleep. So any of you who have either known somebody with sleep apnea or experienced yourself, these kinds of, all of a sudden you're gasping for air and you wake up and you're, suddenly you're snoring and your sleepiness is aroused because you're gasping for air, you can't get enough breath. And by that way, then when that happens, your airway reopens. But what happens too is that it's very brief. An awakening usually, you're unable to, there's during that process, you probably don't even remember that it's happening. You wake up long enough to go right back to sleep, I guess, trying to put that in just easy to say words. Your brain will sense it, you'll arouse briefly, and then you'll go right back to sleep, okay? And the only reason why I know that is because my wife recorded me one evening when we were on vacation in 2012. And she played the recording back for me, and there were moments where there were long pauses between breaths. And then there were moments too where I aroused briefly enough, and it, that is that's very abrupt. It may take the form of a cough or a snore or a snorting, and you'll wake up, maybe with, just an intense type of clearing of your throat. Anyway, she played that back to me, and of course I did that too. And that was very alarming to hear myself sleep and breathe and notice that the gaps between breaths were becoming fewer and fewer and fewer. And realizing from that I'm not getting enough oxygen in. And so that was scary. I needed to get a sleep study. That was the effect all of that had on me. And with the less common form, for some reason, the brain fails to transmit the signals to those muscles necessary to breathe, basically. Well, essentially, this means that the effort to breathe is either cut short or it's not there at all. And you might awaken with a lot of shortness of breath. And typically, that's the same way with the obstructive type. And you have a difficult time getting to sleep at all in some cases, or staying asleep. In other words, you fall asleep and abruptly you wake up, and shortness of breath wakes you up. And if any of you have experienced that, you may wonder if this is apnea or not, because it does tend to be like gasping, like you're gasping for air. So, those individuals who have the rarer form have a little bit of both. And so I don't want to say it's more dangerous, but it does pose some problems as far as treatment goes, especially if it's brought on by using a CPAP. So yes, sleep apnea is a very complex issue, but it leads to so many other difficulties and troubles if it goes undiagnosed and untreated. So this is kind of a pictographic or kind of like a circle of things that happen. There many of you who have had or have experienced sleep apnea, your sleep is restless, and you wake up several times during the night. You can wake up choking or gasping for breath. That often means there's something going on. You experience morning headaches. That was classic for me. I wake up most mornings with a headache and wonder why. Well, because my brain wasn't getting enough oxygen. Yeah, I put two and two together after a while. Maybe you wake up and you have to, frequently urinate. You may have this kind of unrest, or I want to say a brain fog throughout the day, where you're feeling groggy no matter what. Even if you drink coffee or do something else to stimulate, you still feel like you're in a fog. You have low energy. Now that's another signpost. And if you're younger or older, doesn't matter, your libido is decreased or diminished because of that. You experience insomnia. And yes, I experienced a lot of that. And I think at the time too, I was taking medicines to help me sleep, which was complicating matters. So, eventually I got off medications that would help induce sleep. Again, heading back to the top of the page, excessive daytime sleepiness. If you find yourself napping during the day quite often, there's a problem. You have difficulty paying attention and concentrating. That is an outcome of that. Irritability is another outcome. And of course, there's the impact on your partner, spouse, who has to hear these dangerous gasping sounds or loud snoring, or I want to say restlessness as you're trying to reposition yourself and change your position to a better vantage so that you can sleep a little more soundly for a few hours. So there's all kinds of ramifications that go with it. And here's just another depiction. It tends to be a vicious circle, but what happens over time, if nothing is done, is this is going to eventually affect your heart. And usually what ends up happening is the heart has to work harder to pump oxygenated blood, enough of it. And if, because there's all kinds of feedback loops and mechanisms going on within the body that says, feeds, loops back to the lungs and the heart, you got to pump more blood. This organ or that organ needs more oxygen. But what's going to happen is it's going to overwork the heart. And those individuals can, and the risk is high for those individuals to develop heart failure. That's one of the consequences, or high blood pressure. Because when you think about it, not enough oxygenated blood getting to where it needs to go, blood pressure has to increase the output and the exchange at the area of the lungs. So, you could get some pulmonary hypertension, left and right-sided heart failure. Now, there are some links to people who experience, I want to say your brain is altered in some way, and it may have ramifications as far as dementia later on in life. There is a risk. And of course, the other ones is your sleep is disturbed. I think I wish I could quote the study now, that individuals with sleep apnea that's untreated or not effectively treated, usually it tends to cut life by as much as 4 years off of your life. If it goes untreated or undertreated, that kind of thing. So yeah, in the end, there is life expectancy is cut short because of it. Okay, where's my cursor here? All right, so again, I hate to harp on signs and symptoms, but boy, these are things that you need to look out for. Loud snoring is one of them. Doesn't necessarily mean the patient or the person has apnea, but it is a sign. It is a symptom. Episodes which you stop breathing when you sleep. That's when, if somebody like my wife is recording you and notices the gaps between one breath and then the next, and then the next, progressively get longer and longer, that's a big symptom right there. Gasping for air, that's usually a sign, if you're gasping, you're not getting enough oxygen, you're not getting enough air exchange. Awakening with a dry mouth. Anyone who snores out there probably already knows the reason for the dry mouth. Your mouth is wide open and you're trying to breathe that way maybe. And so with that passage of air, it's going to dry the mucous membranes out. So that should make sense, I hope. Morning headache, yes. And that is almost solely due to lack of oxygen during the night. And I'll give you an illustration from my own sleep study. Back in 2012, I had a sleep study done. and I went through the routine. They hooked me up to all their electronic equipment attached everywhere around my head, neck, and body. And I went to sleep. And of course, they have a device measuring oxygen saturation attached to me the entire time. They woke me up around 1 o'clock in the morning when my oxygen saturation was dipping down to 82%. So that kind of a number is usually very dangerous. And they put a CPAP on me for the rest of the night. And my oxygenation, of course, increased because that CPAP stands for continuous positive airway pressure. So you have air being forced through the airway down into your lungs. And if simple air contains just enough oxygen, you don't need to have additional oxygen unless there's something else going on. So you have difficulty staying asleep. And as I look back on it, I should have seen that as a big symptom or sign, rather. Daytime sleepiness. And you can imagine, here I am as a registered nurse. I'm working 12-hour shifts. I'm coming on the unit, not fully rested and expected to work at an optimal level for 12 hours, taking care of 5 ill patients on the ward. What kind of risk I took that I didn't realize, or what kind of risk I was putting my patients under and didn't really realize that. Only in retrospect can I realize that, knowing that after that, the CPAP changed things for the better after that. So I thought, geez, I'm putting myself at risk, but as a nurse, I'm putting other people at risk. Or driving with excessive drowsiness, which means if I'm excessively drowsy, my status of being alert and with it are also decreased. So you can see the ramifications of this kind of thing. Daytime sleepiness, difficulty falling asleep, difficulty paying attention while you're awake. That's that alertness kind of thing, alert and aware. Irritability. These are some things you might say, well, okay, maybe it's just what I'm doing or my job. But, as I look back on that, it was natural for that to be happening because of my own sleep apnea problem that was undiagnosed at the time. Oh, heck, let's see here. There are other risk factors associated, especially with obstructive apnea, excessive weight. It depends on where those deposits of extra weight are. If they're located, and this is where men have probably more troubles with it than women, is excessive weight pressing down, or I want to say encroaching on the airway. That is a problem. And granted, obesity is an equal opportunity type of condition. Men tend to have more troubles with the apnea than women, at least from the studies I looked at and from the numbers. There's also an issue with neck circumference, a wider or larger neck, and that might be directly related to one's deposit of where the weight is going, as well as, hey, this is just how I'm structured. I have a thicker neck. Well, that tends to make sleep apnea much more of a problem, or at least a risk for. Of course, with both of those things, weight, neck circumference, I want to say the muscles, the tension in the muscles, I should say, everything relaxes and falls over your airway, narrowing your airway, which is your throat, basically. So somebody with swollen tonsils or adenoids also, might have a problem with blocked airway. There's so many reasons why an individual might have a blocked airway, including children. And that would be the tonsils and maybe swollen glands there in the back of the throat. Which we're only touching on a few things here that have potential to block one's airway. It certainly doesn't cover all conditions that have the potential to shut one's airway down. And of course, being older, there is a tendency, a risk, along with being male, they're 2 to 3 times more likely to have apnea than women. However, women increase their risk if they're overweight, and the risk also appears to rise after menopause. So it's kind of like heart disease, because I think the numbers are a little different. After menopause, women catch up with men quite easily when it comes to heart disease. And knowing the impact of sleep apnea, yes, anybody have a question? Oh, okay. So knowing the relation between troubles with the heart and apnea, you can see where how women would also have an increased risk of their cardiovascular system after menopause if they have apnea and if they're overweight. So being being elderly significantly increases your chances. Now, risk also relates to family history. If you come from a family of individuals who are either diagnosed or not diagnosed with sleep apnea, then you're probably at greater risk. Same with individuals who use tranquilizers, sedatives, and alcohol. These also tend to relax the muscles, not just all over your body, but in the back of the throat, and worsen any tendency you already have for sleep apnea. Now, smokers are 3 times as likely to have apnea, especially obstructive, because than other people in the general population. Because smoking can increase the amount of inflammation and fluid retention in the upper airway, which is true. So it has a way of narrowing your airway. And I think just because of all the vasoconstriction and I want to say response within the lung and the airways of these irritants that are constantly being exposed, I want to say your lung tissue that's constantly exposed to these irritants and carcinogens, et cetera. Okay. Nasal congestion. I don't know if you're like me, I have a lot of trouble with allergies. It seemed to be year round. When I was a kid, it was mainly in the spring and early summer, but now for me, older, it's pretty much all year round. And if you have obstructions here, it doesn't help your overall ability to take in oxygen. I think it only contributes anatomically to the problem of your apnea. So some might say that, getting that treated effectively will help, lessen that response, or that, your sinuses as being an issue. I mentioned congestive heart failure. That's usually at the top of the list because your heart takes the biggest impact. High blood pressure associated with heart failure. Now, why is type 2 diabetes an issue? Because I'll tell you why. Because people with poor sleep end up at least they're at risk for, I want to say, eating more during the day, especially earlier on. Thinking that they need more energy, so they need to take more calories in, and it has a net effect of making you more susceptible to diabetes. There's less control over that because of your trouble with apnea. Same with individuals with Parkinson's disease. It increases their risk of obstructive sleep apnea. There are other conditions like polycystic ovary syndrome. There are other hormonal disorders. And this may be where postmenopausal women have begun to experience an uptick in apnea. because the hormones are not the same as they were prior to menopause. There are other individuals that are prior to stroke or chronic lung diseases such as asthma that also have an increased risk. Excuse me a second. So maybe you get a glimpse as to how other conditions can contribute to apnea or at least put you at risk for it. The central apnea is a little bit more, I don't think it's as particular, but it tends to affect middle-aged and older people. And especially older people, they have a higher risk of the centralized form of sleep apnea. What it is that actually makes them at greater risk, I don't know is as well known as the obstructive type. The central apnea form, again, seems to be more common in men than it is in women. Not sure about the studies on that one either. But they're at least apparently, at least to the numbers, it appears they're larger in that cohort, or at least the ones that they've been able to sample. Men versus women, men seem to have more episodes and more trouble with it than women. The heart disorders, the greater increase for congestive heart failure, no matter what I want to say, no matter what the source is of your apnea. Narcotic pain medications. Now, they can have an impact, especially from a chemical standpoint. They can have an impact or contribute to the centrally acting kind of apnea. So when you think about it, though, narcotics like methadone, Demerol, hydrocodone, morphine, it relaxes. Not only does it change your perception of pain, but it tends to relax the same way sedatives would. It has it has a sedative property to it. And so if you're mixing all these medications along with the propensity to have that form of apnea, it just makes it worse. If you've had a prior stroke, having had a stroke increases your risk too. Or if you have some sort of treatment emergent type of apnea. In other words, if you're using a CPAP already and the CPAP tends to be a failure for you, there may be something else going on as well, and another form of treatment needs to be sought. If that makes sense, let's say you've been using a CPAP and at first it works, but as time goes on, the CPAP is not as effective as it once was, no matter what kind of an appliance you use on your face, then you have another problem going on that's beyond obstruction. There's another problem going on which lends itself to the central form of sleep apnea. Now, again, complications and consequences. And I think anyone with apnea might identify with some of these. There is a greater risk of depression. The high blood pressure makes sense. Heart arrhythmias because of lack of oxygen, nutrients, adequate blood supply, etc. The arrhythmia makes sense to me. You're going to be exposed or be at risk for more troubles with the heart that way. Oxygen levels drop. Diabetes risk increases. Heart failure, one side of the heart or the other begins to fail. Trouble with impotence. Obesity is a problem that lends itself, and I'd say there's probably a two-way street there because of the propensity to eat more because of your undiagnosed apnea or poor sleeping, making weight a worse problem for you. Having had a stroke, troubles with anxiety, the knowledge that you don't sleep well or wake up gasping for air will produce anxiety. And brain fog that's almost constant is an issue. You go around walking around through the day doing things with a constant kind of numbness in the head. You can see the seriousness of this problem. Okay, we have already talked about a lot of these things. There is a couple other things I'll mention. The metabolic syndrome, which is a multifactorial syndrome that follows sleep apnea, the hypertension that can result, the diabetes, the type 2 diabetes that has a potential to result from your apnea, higher blood lipids, and increased waist circumference. That would have to do, of course, from either your current diet or a diet as a result, that vicious circle as a result of your apnea. And of course, increased waist circumference, again, there's more pressure added to your upper abdomen. And so it's all of those things are linked to cardiovascular disease in general. But this is what metabolic syndrome is as it relates to sleep apnea. So the risk of complications from surgery and anesthesia, if you ever go under the knife and have to have general anesthesia, they want to know right away, do you have sleep apnea? And do you use a CPAP? Because during surgery, inducing anesthesia and then pulling an individual out, they have to be very careful what they do and how they use anesthesia in those patients. If they give them too much anesthesia, they tend to take longer to pull out of this surgical procedure simply because their sleep apnea makes the process of waking up even worse. Okay, so they need to know that right from the start. Liver function studies too tend to be more elevated, and that may also be directly related to your diet, and it's associated with a fatty liver in the end. And I'm sure that doesn't develop quickly, but probably over time. Now, this is what a sleep study looks like. And yes, they could put you on oxygen versus CPAP, depending on how severe your apnea is. And treatment also follows the severity of your apnea. May not be very bad at all. In other words, and I'll get to this too and more, I have it up on the screen. It depends on how bad your apnea is and how much you and your physician are willing to say, okay, before we do this, let's try this, this, and this, without having to get radical by ordering or having you see a physician to, I want to say, remove adenoids, tonsils, restructure something related to your jaw, or I want to say resorting to other surgeries that either shrink tissue or remove tissue altogether by excision. So we try to get individuals to do some of the other measures first. Oh shoot, let me skip to the treatments and I'll go back. If it isn't too severe, lifestyle changes are usually all that's needed to change that, okay? Quit smoking, lose weight, treat any allergies before resorting to other measures like the CPAP and beyond. If it's just a matter of getting these things changed, then you can effectively address that without having these other things. Severe cases, where CPAP is even not effective might require the surgical interventions. Again, to remove tissue, ablate tissue, which means to shrink the tissue at the back of the throat, or getting a stimulator placed that actually is placed in the abdomen, much like a pacemaker or a spinal stimulator. This is placed in the abdomen with leads that go all the way up into your tongue. And what it does is it delivers electric shocks, if you will, probably electric signals for the tongue to move in order to open up the airway. It sounds a little strange, but I did a little reading on the hypoglossal stimulator, and it makes sense. That way, opening up the airway without it ever closing, or without having the severe response where it completely closes. So the stimulator sends a signal, moves the tongue, simply put. So going back really quick, some of you may have a CPAP that looks like this or something like that. And so, yes, this is what people wear with a CPAP. Typically is this nocturnal polysomnography. That is the typical test. They do have home tests that you can go home with. It's simplified. However, it doesn't measure a lot of the other things that I want to say in-clinic version measures, like doesn't measure your heart rate, doesn't measure blood oxygen levels, airflow, and breathing patterns. So it's limited. Typically, this is what you'll go through is the nocturnal study in a sleep clinic. Let's see. No, I had that completely in reverse. I'm sorry. It's limited in detecting all cases of sleep apnea. Usually the home study can only measure things like heart rate, oxygen level, airflow, and breathing patterns, but it doesn't detect a lot of things that are detectable, when you're in the clinic. Sorry, I had the cart before the horse there. Because with the other type, you're hooked up in such detail they can detect everything they need to detect in one clinic course. And they can tell right away whether this is central or obstructive or both. And that's where the home tests are not sensitive to that kind of thing. Okay, let's go forward. Now, some of the procedures, again, they might try, there are so many things that can be used, placing, I want to say ablating places in the back of the throat, shrinking the tissue, for lack of a better way of putting it, or I want to say that opens the airway up. Troubles with weight, maybe that individual needs to have a surgery to do something to the stomach in order to help with, I want to say, with their diet and what they take in that's maybe contributing to the problem. And of course, there are other appliances and other devices. There's one that can be inserted into the mouth. It's almost like a bite block, but it's meant to thrust the lower jaw forward, because a lot of people who experience apnea have a huge overbite. And so this appliance adjusts and allows the lower jaw to become more in line or just slightly forward in order to open up the airway, simply put. That's what it does. Or there's this device here that gets implanted in the upper chest and has a few leads that go to the tongue. And when it's detected that, those, muscles aren't moving, because there are leads that will detect that and send another signal back to move the tongue. It's done with an impulse like that. And here's a little bit bigger picture of those appliances that can be used and adjusted. I've heard good things about it as far as opening up the airway if it's the problem with the jaw. Again, it only addresses part of troubles with sleep apnea. Again, I don't know if that's going to change everything about your collection of tissue in the back of the throat. Maybe an ablation or a removal of tissue is the answer. And or something like this stimulator, might be necessary as well. So this is just, I think, in terms of treatments, you might be able to use a different kind of device. The CPAPs of 15, 20 years ago are no longer in use today. The technology keeps improving. There are some that auto adjust to your normal breathing. In other words, the device detects your normal breathing and will actually try to keep that pattern up while you're asleep, which is good. Others, other units might actually have to use a bilevel positive airway pressure as well if the CPAP continuous pressure is not working. Basically, these provide more pressure when you inhale and less when you exhale. So forcing more air in, and maybe just the normal or less of air going out. So, so that's a possibility too. The oral appliances, I've heard of those being used for the last 10 to 12, 15 years, and they're also getting better. It's a very easy, if it's a simple method, of just wearing the thing and all of a sudden everything changes after that appliance is worn and used during sleep. And it takes care of a lot of snoring and some of the milder forms of apnea. So that's a positive thing that's likely to be a little less troublesome than trying to find an electrical hookup for your CPAP or whatever, your BiPAP. In some cases, you may be that individual that needs supplemental oxygen to go with a CPAP device. There is another device called an adaptive servo ventilation. This is kind of I think it's more recently FDA approved airflow device that learns, I think, kind of lends itself to that auto CPAP, but it learns your normal breathing pattern and it stores the information in the device itself because there's a built-in computer connected inside the device. So after you fall asleep, the machine actually maintains the normalized pressure and breathing pattern for you automatically to prevent pauses instead of, having to force air, through those pauses during the night. And that's where a lot of people have trouble actually tolerating the CPAP. It's constantly forcing air and you feel like you're drowning in it. I had a lot of trouble the first year adapting to the CPAP. Until I finally found the right appliance to apply to my face that wasn't feeling like I'm suffocating, et cetera. And a lot of people who use a CPAP for the first time don't like it because of the feeling of suffocating. So let's see. The nerve stimulation, we talked a little bit about that. The hypoglossal nerve stimulation helps keep the tongue in a position that keeps it away from blocking the airway. I guess this is still, I don't want to say experimental, but I don't know if it's fully FDA approved. Now the tissue shrinkage, the ablation, that's being currently used. Yeah, it says one study found this to have effects similar to that of tissue removal, in other words, surgery, but with fewer surgical risks involved by getting put under anesthesia and other things that are involved with surgeries in general. What can you do? Lose weight, exercise, avoid alcohol and limit use of alcohol, avoid it altogether. Limit or avoid tranquilizers and sedatives as well, because they're just going to contribute to your sleepiness. And And it may induce you to sleep, but it won't help you stay asleep. Sleep on your side. I learned to do that right away rather than on your back. Limit or quit smoking altogether. Keep a diary of your sleep. Now, I didn't do this religiously. Every now and again, I would to tell, in order to have something to tell my doctor. So, signs and symptoms, problems with the device, problems with falling asleep. Write down all your medications, because some of them may actually, factor into your apnea. So, just to reiterate, do you have this? Well, what are the risk factors? What are the signs and symptoms to pick up on? And then what actually are the ramifications? Because some of these things may cause heart failure, stroke, hypertension, or at least put you at greater risk if they're not directly, building up to that. They can put you at greater risk, really, for all of those. And okay, so gosh, it's a result partially of anatomy, partially of a mechanism from the brain to the muscles, and it's a chronic condition. Apnea, it tends to be a chronic condition. So treatment options would be get those allergies treated, have the surgeries. Maybe it's related to the jaw and jaw position, especially the lower jaw and the position it's in. Try some breathing techniques, although I've never found those to be that helpful. The circular breathing techniques, breathing in through the nose and out through the mouth. I know for some people that helps. I didn't find that to be, very helpful to me. But it's something you can do as a pattern of breathing. Lose weight. And then, of course, stick with your CPAP therapy. And, or if you need to find the right fit for the appliance use so that it's going to be on comfortably and it's not going to, hug your face, so to speak, and cause some, feelings like being smothered. So that's it. Basically, this is the end of the wrap up. Any questions at this point? Any issues, troubles? Anybody out there in Zoom land have apnea?
I don't think I have apnea, but I do wake up with a dry throat. And I was just listening to, because I never heard of that before. So it was just, that's something to, wake up, I have a very dry throat.
Right. And that's typical of people who are mouth breathers. There are people who breathe really well through their nasal passages. And there are others that, the jaw relaxes like other muscles up here, like the tongue and the jaw, they relax, they become slack. And that is when the tongue begins to fall back on the airway. Or it only partially obstructs the airway, and then breathing continues this way best it can. And even if you're wearing a CPAP and your jaw slacks enough, you're going to wake up with a very dry mouth because it'll dry your mucous membranes out. It doesn't take long to do that. So some people resort to what's called the jaw strap. I have one of those at home. I have to use it occasionally. It wraps around your chin, leaving a hole here, and then wraps around your ears, leaving a hole on either side, Velcros to the crown of your head. And that keeps the jaw in place, closed, so that you're only breathing through your nose, provided you don't have troubles with allergies, plugged and stuffed sinuses, etc. I have had to resort to using, a 12 or 24 acting medication to help with the troubles because I have them year round. I don't get away from them. So, So that is typical and answered a lot of questions I had about my own troubles with dry mouth. Makes sense. Jaw goes slack. You're breathing best you can through your mouth. You wake up with very dry mucous membranes.
Thank you.
Sure. Anybody else? Questions, concerns, worries, issues? Something else they may want to know about apnea or sleep apnea?
You suspect someone has sleep, your spouse has sleep apnea, do you find it through their medical claims or a sleep test?
Oh, okay. Kevin is asking about if you suspect your spouse has sleep apnea, how do you go about getting this polysomnography test in a clinic? The best thing to do is to take the issue to your primary physician, let them know what's going on, what kind of signs and symptoms, what kind of things, you know, hey, my spouse is complaining, hearing this happening from me. I was wondering if there's a possibility I have sleep apnea. And that's when exploring some of these other things, treatments, et cetera, lifestyle changes, you know, begin to surface, and your doctor might say, yes, do these things, but let's get a sleep study test too. Typically, that is what happens. You know, he'll take an inventory of, you know, what's going on and say, you know, work with you to maybe adjust and change those things. And then let's get you a sleep study here. You know, they'll make the referral, you'll make the appointment, you'll come in and you'll get the sleep study done. Usually it's overnight. You'll come in the evening on any given day. Usually it's a day of the week though. And they'll keep you till about 6 o'clock the next morning. And then they'll detach you from everything and you go home. But they'll put you in a room where you just go through your normal state of getting ready to fall asleep, and you do so. And then they record everything from your muscle activity, lungs, oxygenation, heart rate, etc., while you're asleep. And that's when they can come up with, you know, everything they need to know about what's really going on. So yeah, that's a good question, Kevin. And hopefully that helps everyone out there who's thinking about this. Because I know this was something I had many years before I had the sleep study. Probably a good 10 years. And it makes sense to me because I've never been overweight. However, the idea of the other form of sleep apnea being an issue makes sense to me. The central form, the why the brain is not, you know, sending signals electronically through the nervous system. Why it's not sending those signals is another issue. I don't know why. When the physician talked to me about my results, she said, yes, you have a mixed form. You have a little bit of both. And yeah. So she said, well, you know, even you may have had this for a while. And even if your tongue doesn't slide and block or tissue isn't the problem, the centrally acting issue of your lungs and the muscles surrounding your lungs, that not kicking in, that's a problem. And you've had this for a while, no doubt. So I am glad I got it detected and taken care of when I did. I was doing myself no favors, or my spouse, my wife, of going that long, having snoring wars, for lack of a better way of putting it. And then, you know, her being scared to death of my breathing patterns, because she'd kick me, I'd turn over, and I'd be on my side naturally, and things would improve. It's when I'm sleeping on my back, that's the issue. And it doesn't seem to matter whether I have pillows under my head or not. It's sleeping on my back in general that's tends to make things a lot worse. And so, you know, I'm actually looking at some of these things you know, 10 years likely I had it. You know, I tend to watch now for signs and symptoms of, does this had some long-term effects on my brain? Deprivation of oxygen, for instance. What's the long-term effects of somebody who's not getting enough oxygen to the brain? I don't know right now. I'm looking at those matters. But what about my heart? What about all these years of my heart has had to work against having less oxygen and then having to, you know, be part of that mechanism where, you know, it has to pump more blood faster and faster to get that to the tissues in my system. And that's going to overwork the heart and cause heart failure after a while. You know, what about diabetes? I'm always worried about that. You know, what are the chances I inherited any of this? Well, probably there's good chances. Both my poor parents snored, and I know my dad had troubles with that. He would wake up out of a sleep, and I oftentimes, you know, catch him napping, and he was snoring up a storm, and then he wouldn't breathe. All of a sudden, he would snap out of that, breathe again, and begin the patterns all over again. That was especially camping. So I knew about that firsthand. So then I recognize it only in retrospect. So yeah, this is an important issue. And apparently it gets more important with aging because the aging population has to deal with this. I mean, the fact that of the aging population, it's like 1 in 4 or 1 in 5. And the general population, apnea represents about 1 in 15 maybe of the cases. But that's, I think it's even more prevalent than that, to be honest with you. I think because there's so many cases that are undetected, unnoticed, undiagnosed. So, you know, I think it's more prevalent than that, but I can't speculate. I'd like to, but because I can tell you as a nurse for so many years, patients would come in, many of them would stop breathing. And I'd count their breathing overnight just to make sure they were still breathing. And many of them, it's like, okay, what's going on? Because they would be breathing less than 10 breaths, 12 breaths a minute. I thought, well, maybe it's the narcotics, you know, but maybe not. Maybe this is a central form of apnea, or it's an obstructive form of apnea, undetected, and I want to say undiagnosed with some of these individuals. So it makes sense now looking back in retrospect, since I don't work in acute care any longer. I can still look back on those things and say, aha, yes, that is exactly what that was, but I didn't know it at the time. So anyways, I won't keep you any longer unless you have any, you know, questions or issues, or is there anything regarding sleep you want to see covered in the future? Like, you know, insomnia is another thing that's completely separate. So is, there's another, oh, for heaven's sake, I can't think of it now. There's another form of sleep disorder where people just fall asleep at the drop of a hat during the day. Oh God, I'm forgetting the name of that kind of sleep disorder. That's another one that can be quite dangerous too. There are other sleep troubles out there as well. But, you know, if you have a suggestion, you know, send it through a future chat, or, you know, send it to the, you know, the cardiovascular wellness email, I suppose, and we can pick it up there. So if nothing else, I'll let you all go. Thank you very much. And you all have a great rest of your day.
Thank you.
Thank you.
That was good, informative. Yeah.
Awesome. I'm glad to hear that.
It's funny because her sister's a doctor and does sleep studies.
Oh, is that right?
She's so stubborn about wanting, I suggest the idea of a sleep cycle.
You know, I was resistant to that at first.
I think recording, because I've sat there and counted